Thanks, Diane. And morning, everybody. Welcome to this conference. It's so lovely to see so many of you join us this morning. As Diane mentioned, my name is Melanie Clarkson. I'm also linked to the Advanced Practice Research Academy as well, so you'll hear more about that later. But in this session, I want to explore some of the perspectives of collaborative leadership, but mainly within the higher education situation and space. So like a good lecturer, I have some aims. So really sort of thinking about why we do it or why we should do it, and what does it look like from an educational perspective. Also some of the enablers and challenges, because, this is not actually as smooth as what we would think. And I'd like to be able to demonstrate this through some current experiences that I have of working with a few international communities of education, so some international universities that are looking to develop their educational provision and further collaborate in advancing practice education. So thinking about why, we obviously have quite a wide range of multi-professional programmes that have started to be accredited by the Centre for Advancing Practice. But within that, we've got some really niche roles that we need to think about. So it's fabulous that people are able to learn from a multi-professional perspective, but we need to make sure that the programmes that we develop are actually something that is beneficial for the practitioner. And we have practitioners who work in quite broad sort of scopes that are quite common in some of the areas. So if you think about accident emergency, but then we've got some really niche practitioners who might actually be developing in some very unique spaces. So we need to make sure that the programs, the education provision that is there is suitable, but also sustainable. So we need to think about actually how that innovation in our development of programs allows the person to get what they need from that education. We can do that through that collaboration of leadership across the HEIs. So it might be that some of the resources around some of the education might not be within your institution, but they may be close by. And actually having that collaborative working relationship means that we can make sustainable programs as we perhaps share and gain knowledge around other wider modules that are available to practitioners to be able to bring into their overall pathway of education. We also need to think about sharing best practice in some of those unique challenges. So it can be quite difficult to think about some of those niche roles, and it can be quite challenging within the overall environment of higher education at the moment. Higher educations are classed as a business, so they have quite a high fiscal interest in terms of monetary values. So it's about making sure that we've got programs that, yes, meet the requirements and values and missions of the university, but also meet the requirements of healthcare and for the practitioner as well. So there are some unique challenges that actually, if we collaborate, then we can actually share some best practice of how to overcome some of that. And that might be in some of our innovation of program design, use of artificial intelligence, use of simulation, use of how we might be able to look at assessment. So when you're looking at innovation program design, yes, there is underpinning knowledge that we provide through a higher education institute, but actually, how do you assess that? How do you think about the innovation of assessment? And actually sharing best practice through that collaboration might then develop and make programs stronger. We mentioned before about sustainability of modules. There also needs to be that collaboration around sharing of educational resource. So within a lot of our practice, there's a lot of technological advances. And actually, from an educational point of view, you may not necessarily have the resources to be able to provide development in those areas. So actually collaborating across the educational platform and also across healthcare with clinical academics, it means that we can think about actually how do we innovate and use the best educational resources that are out there to provide the best programme. And all of that obviously aligns with our stakeholder needs. So overall, that should be nothing sort of new in terms of why it should happen. I think we're all probably in agreement that there needs to be collaboration across the educational landscape. And one of the reasons that we want to do this is that we're still all clinicians at the heart. Yes, we've moved into academia, or for many people, still have a clinical role. So we still want sustainable, effective, and efficient programs for our healthcare workforce. We still align to our professional values of our base profession, of that with the NHS constitution, and also with our HEI values and missions as well. But ultimately, we want to make a difference. We may have moved into an educational space, but we want to make a difference to our patients and to healthcare. So how do we make this happen? How do we overcome some of these areas of challenge? So there's obviously huge benefits to that collaboration, about gaining a new perspective about what happens perhaps in another locality, another international area, what happens in a different discipline, or looking for different resources. So there's a quote there by McFarland to show that there are ways of which we can collaborate. So I mentioned before that higher education institutes are a business. So sometimes it can be really challenging because of the boundaries of intellectual property, of not being able to share the context of modules and of programs, because ultimately it's in a market, it's competitive, it's in a business. But there is a way for us to be able to work collaboratively without necessarily sharing that intellectual property. And this is where we can utilise our collaborative leadership to be able to look at how we might be able to do that. I'd really like to share with you this table, which comes from the McFarland paper, around collaboration as a moral continuum. So there's different ways of which we might be able to collaborate as an educational institution with other educational areas, so things like the imaging academies, other universities, other trusts that might have educational modules that they have. So there's various other ways that we can do this. So one of them is around collaboration as intellectual generosity. So a very altruistic nature of just collectively sharing ideas of how we want to advance our healthcare education. So this is sort of a free exchange of any ideas and data. So it might be that you have got this collaborative group with a number of individuals that you might then be able to explore some of those ideas. So, for example, currently I'm working with some of the universities who are used to setting up very profession-specific advanced practice programs. And they want to learn around developing multi-professional programs because within their country, that's very new to them. So actually there is an opportunity for some intellectual generosity where we can have a collaborative discussion with them, sharing our ideas of how we've developed multi-professional programs, but then we gain back from that in terms of actually some of the niche challenges that they have, how they may have overcome them, learning more about their educational institution, learning more about their healthcare jurisdictions, etc. There's also collaboration as mentorship. So just as it states, working with less experienced colleagues in a certain area. So it might be that there's a new university setting up there close to you, or it might be that there's somewhere in a trust where they're wanting to set up something, and then you may be able to offer that sort of critical friend in being able to look at the overall curriculum design. And equally so, they can feed back into you of being a critical friend in terms of what it is that is delivered within your programme. There's also collaboration as communication, so being able to disseminate some of that work. So one of the universities that I'm currently working with, we are also linking with that collaboration of communication, and we are developing a commentary paper to be able to share what we're both gaining from that relationship. And obviously then there's the performativity. So then we're getting sort of that research. So what we're going to develop into looking at the impact of our educational programs, the impact of some of the assessment, and then there's obviously the joy of the co-authorship of the papers as well. Now, I have been sneaky and taken the benefits out of this table, but there is obviously some negatives that can occur. And the negatives can be that perhaps one part of the partnership might take more than the other. And there also might be some conflict within that. But actually, what we can do is we can make sure that by being aware of the enablers and challenges, is that we have that respectful relationship from the outset. So just like with collaboration in research, everybody will be in that conversation to be able to develop impactful programs and to benefit them, to provide benefit to the healthcare and to the institution. The other thing to bear in mind is there's a lot more commissioned projects now that are looking for collaboration across institutions and looking for that innovation. We're looking for leaders in this space who want to encourage that development. So that might be around developing memorandums of understanding. It might be about developing visiting professorships or visiting lecturers. So there's ways to be able to enable this to happen by having that respectful decision on how you're going to collaborate and how you're going to implement that and what each of you is going to get out of that. So what is the most experienced academic going to get out of that, and what is the person who's gaining from that information? So some of the challenges are about managing conflict, and that conflict can come from a number of different areas. Some of that might be from your systems leaders. So because of that fiscal market and sort of mentality around HEIs, they might be very risk averse to be in a relationship like that of collaboration with other institutions. But one of the ways around that is to speak in the same terminology, to recognise that you might not be sharing intellectual property, but more about that mentorship and advice and research of coming together to develop niche programs. Because of the sustainability issues of having a relationship with others, you also need to think about the QA standards. So thinking about actually, for example, at my institution, I don't offer all of the modules that some of my practitioners need. So I might say to them to go to another institution. I then need to have confidence in that institution that they've met the QA standards. It's required for the practitioner so that we can AAPE that in. And we also need to recognise the fiscal issues as well and be able to have that conversation. But it's equally about getting the stakeholder information with regards to everything, as same as when you're in clinical practice. The way to inform any form of collaboration or change is to have information from the patient. For a HEI, it's to have patient information from their stakeholders. So get that information to be able to develop that collaboration of what is needed within our programs and being able to develop that. So the take-home message from me in terms of collaborative leadership within HEIs across the region, nationally and internationally, can happen and can benefit both parts of the partnership. And there's a benefit of that collective and innovation among a group of academics. HEIs are in a very challenging environment at the moment, and actually those who work outside of the traditional box and actually enact in this model will be able to adapt to the challenges of demands of programs, the demands of what the educational environment looks like. So I hope really that some of this has made you sort of think about how you might be able to collaborate in this space, and that it's not just around intellectual property. Thank you for listening. And it's just a reference there to the McFarland.
Thank you, Melanie. So I think it's over to me now. So my name's James Pratt, as we said earlier. I'm the trustee for advanced practice at Nottingham University NHS Hospitals. And what I wanted to do is talk to you today about what it means to collaborate from a leadership perspective when thinking about education and how that can support the clinical pillar. And the way I thought best to do that was to talk you through some of the journeys that we've been on in the organisation and the ICS and within which I work. So I think, first of all, just to reflect on what is advanced practice leadership, well, it's broad, it's wide. From my role perspective, my role is to lead advanced practice across a large secondary care organisation. And we're seeing these roles evolve more and more across the country. across the four nations, sorry, which is absolutely brilliant, because what we're finding is when we have clear leadership of advanced practice, it really helps in developing collaborative models with other organizations, whether that's HEIs, other employers, or other key stakeholders. When I reflect back to when we first started investing in advanced practice in this organization, which was a good 15, 20 years ago, and we had a program running at our local HEI, although there was some collaboration, it was very much HEI led, with us as employers purchasing places as such on the course. And that's very much changed now, and that we actually work in clear collaboration and partnership with that group. But developing across that clinical education pillar as a leader isn't just collaborating with our HEIs, it's collaborating with other employers and other people within our ICS, and working together to try and drive forward to advanced practice. And we're particularly focused on the education pillar today. So it's how we can then think about developing our educators, developing others, having programs of education which meet our needs as well. So the key bit for me is making sure that we have clear partnerships. Now, having a lead in an organization has allowed us as an organization to build those partnerships with our local HEIs, but just as much, it's so important to have people in our HEIs who understand advanced practice, who are leading on these programs. We're very lucky here in that we have quite a mature advanced practice team at our local universities who we engage with both of them. And building those partnerships with these people over years and years, I mean, we've worked very, very closely together and have done for a long time, as do many of our employers across the country, has allowed us to really sort of implement advanced practice across our ICS in lots and lots of specialties and across lots of different professions and lots of different roles, and really understanding what our responsibilities are in that pathway. But also now thinking about what those next steps are as it's firmly embedded, is actually how else can we support partnerships from an HEI perspective, from developing them as employees of HEIs, but also our advanced practitioners and others. So I'm going to focus on a few different pieces really, which we've done over the years, and that's around sort of curricular development and the apprenticeship. I want to talk about how we can support clinical capability and governance together through partnership, collaborative working, how we can develop educators and learners, think about how actually income could be generated for both sides from the collaboration, and how that can then open up new pathways of education going forwards. So the first thing I just want to talk about is the apprenticeship. So we've worked with our HEI for many years, as I've said, around various advanced practice programs. But when the apprenticeship standard was released and we implemented that within our local HEI and us as an organisation, it sort of brought our collaboration up to a next level, in that we were then working very closely developing that curriculum and making sure that curriculum allowed us to meet our needs as an employer, but it also improved that relationship, because obviously it's very different from compared to when we were funding classically at that time through HEE funds or other commissioning pathways. So what that's allowed us to do from the introduction of the apprenticeship is to embed workforce planning models which are collaborative with our universities, in that we can plan now for workforces over years rather than single cohorts, and we could do that alongside our university. So we could start thinking about how our pathways into advanced practice from a workforce planning perspective would be over many years, and we can start to think about what would be our educational requirement in that time over the next few years and how those programs may look, and actually we can then build curriculums around that. Having the apprenticeship scripting off the job training is really, really useful for many organizations who have struggled to put their practitioners through pathways because they're not able to support them to be off the job. And actually this giving them something that they have to do has really opened that up for many employers. And I think that's really helped really helped to build relationships with HEIs and the employers. The tripartite meetings have really changed our relationship in a great way, in that we now have a process where it's easy for employer, trainee, or student and HEI to raise concerns, to build up collaborations, make platforms about how we can start to move things forward. And that's been really, really important for us, and actually really improve those relations. Not just I have a partnership and collaboration with the university from an organisational lead perspective, but it's allowed our specialty leads, our supervisors, to build those relationships further as well. And the onboarding process to the apprenticeship has really helped as well for us to sort of be more joined up and collaborative when we're appointing advanced practitioners. We always had AGI representation on our interview boards, but with the apprenticeship, that sort of stepped that to another level, and it helped us to think about how we could do more around engaging with potential advanced practitioners going forwards and taking a collaborative model when we're thinking about that. So clinical capability as an employer is really, really important. We need to make sure that our advanced practitioners are competent and capable, and there's appropriate assurances in place that they can provide care to the patients, which you see our patients feel safe and our practitioners feel protective, and we have appropriate governance pathways for that. Now, there's a big role in sorry, I haven't moved the slide. Sorry, there we are. There's a big role between us and the university in knowing what our responsibilities are within that. And actually, what's the responsibilities of the employer in ensuring that we have advanced practitioners who are clinically competent, and then where does that line draw with what we want from the university to deliver and getting those partnerships? That has to be a collaborative process. You can't rely on one to do all. And I think sometimes, often in the past, there has been an emphasis in that the HEIs have to deliver everything, but actually there's a huge amount that has to be delivered internally as well, not just from a supervision perspective, but ensuring that we're developing people clinically. And then also, how can that work with partnerships by supporting other students on pathways and courses? So we've been very lucky in that our programs are all accredited, and they meet what is the national sort of capabilities with advanced practice. But what's been really important with our partnership and collaborative working with our local HEIs is that we've built in our governance processes around clinical competency and capability alongside the curriculum, but also reflect what we need as an organisation. And there's lots of examples of how that's been done across in the partnership. But particularly is having a portfolio of clinical competency and capability which meets our needs as an organisation, meets the needs of the HEI, but also meets the needs of the individual, who's of course needs their individual development plan as well being put into that. And having that portfolio utilized as part of the curriculum and actually having credits attached to it. There's many organizations who are having to run internal portfolios alongside HEI portfolios, and actually building a collaborative relationship from that makes that a far easier program. And then thinking about how then we move our advanced practitioners into working in what we would say qualified advanced practitioners in this organization. We use like a Viva process, that which involves the supervisors, the employers, the advanced practitioner, and the university as well, where we can then review that portfolio, meet the needs we need from a governance perspective, but also from a governance perspective from the university to move them forward. But it's credited, which makes it far more valuable for both the HEI and the student. We've been really lucky in that we've worked for a long time in developing e-portfolios with our colleagues. We, as an organisation, we helped develop a portfolio which could be used by anyone on the course. But as that's evolved over time and as credentials have come out, what you find is that many practitioners have their own portfolios related to specialty or profession. Say for RChem, for example, or for us as a local hospital, we have our own NHSE portfolio, and it's how that's then supported by the universities as well, that being part of the program, we have a really good relationship about how that can be utilized and reflect each other's needs. That only happens though through partnership working, and what that does, that eases the employer burden, the university burden, but also the trainee burden as well. By working closely with our HEIs and others, we've been able to come up with some really good opportunities to developing our practitioners within the educational pillar. So we do lots with our university. We offer honorary contracts to them, and that works both ways. So we have lecturers over there, or leads even, of the advanced practice pathway, and we can offer them clinical time so they can stay clinically capable and competent as what their needs are. But we also have joint appointments where we've got people working within the ICS and the surrounding areas as practitioners who are then working within the faculty as well within the university. We've got a system for lecture support and fees, so they can come and support other postgraduate programs as well as advanced practice. We can't expect the universities to deliver every single thing from a clinical perspective, which is a challenge for them. You can't have a faculty which is absolutely vast. But what we do have is an alumni of hundreds of advanced practitioners who have been to our local universities, and it's processes we've set up so they can be utilised in the delivery of other programs, which has been really, really useful. We subcontract to help support our clinical skills day. That's brilliant from the perspective of our alumni from the university still get to come and engage with the masters, but it also means they develop as educators. It also means that we've got current advanced practitioners who are in the workforce, who have been through the program there to support as well. And then we've got other areas that we've worked out developing our practitioners, and that we've developed many of them into teaching fellow posts organisationally. We have courses we've set up locally led by advanced practitioners to develop people across our organisation as educators. There's lots within this space which has just evolved over time. And what that's allowed us to do is to actually start to generate some income. So we generate income from subcontracting, which has been really useful because then that allows us to generate funds, which then pays for our portfolios, but also has led us to be able to develop what we call supervision shifts in the organization. So we have practitioners who have a day where they're just there to supervise, do work-based assessments, and we can open those up across the ICS for others to use. We've used it to develop people to go onto courses who want to take on certain pathways and pillars, which has been brilliant. But at the same time, it also allows the university to income generate because it increases their faculty so they can think about that wider scope of delivery of what they can do. And that really brings me on to something which we've seen develop over the last 3 or 4 years, in that we've got contracts with different universities and relationships with them, but what we have started to develop is different postgraduate pathways within the universities which are led by advanced practitioners. Now these pathways we've seen evolve from critical care, HCOP, we've seen it with renal, we've seen it across lots of emergency medicine, acute medicine. Well, these are programs which are multi-professional, which aren't at advanced practice level, but are seen as something which someone can develop within their specialty. But we've got expertise from the advanced practitioners delivering that, and they're being supporting the universities to deliver those from a joint contracting perspective, which allows us to access those programs for our employees, but it also allows for the practitioners to develop as educators as well. And we're seeing that now with the ECP pathways, developing CPD pathways. So there's lots and lots of opportunity there. I think there's opportunity at the end for us for questions. So I'll now hand you over to Matt. Thank you.
I definitely got internet, so I was just panicking slightly. Hi everyone, it is absolutely an honour to be here, and thank you for the invitation, and congratulations to AAPE on putting together such a wonderful conference. So I'm going to talk a little bit about sustainable and collaborative advanced practice research. Diane's already told you a little bit about who I am, but these are my sausage dogs who may well come in the background. I'm trying to keep them quiet until I finish speaking. So, thinking about research, why is research so important? We all know of this, and I just want to remind us, because I think the figures globally are absolutely stark. But thinking about, we all want to improve efficiency. We all want to increase access for our patients. We all want better health and better health outcomes. And fundamentally, which is always the heart of everything I do, we want to have a better patient experience. And there are significant global health challenges that we need to be aware of. So we know that by 2030, we are hoping to achieve all of the universal health coverage, and WHO have set us that challenge. But will we meet it? If we don't get things right in terms of research in the advanced practice arena, then we are going to potentially have issues in showing what it is that we do as advanced practitioners. And that is something that we do need to think about. We need to think about how we ensure that we promote the amazing work that we are doing across the whole of the UK. We know that we have over 400 million people who globally lack access to one or more of the essential health services. We know that we have over 100 million people falling into poverty, paying for essential services each year. And we know that each of our countries spend around 32% of our health expenditure comes from out-of-pocket payments. And we know also that we have at least 40% of the world's population lack health and social protection. So what can we do, and how can research make a difference to this? So if we are going to make sure that we sustain research and that we improve our collaboration, we need to ensure that we have robust research in all of health and social care, because we know how it's going to improve services. We all need to think about how we can collaborate and be more strategic. And we need to remember that we need to bring along everybody on this journey. So we need to think about those who are yet to come into advancing practice, those who are trainees, those who are clinical, but also all of our other stakeholders, including educators, researchers, leaders, and policymakers. And if we are going to be sustainable, we need to maintain and improve quality research in all areas and make sure we have funding. And we're going to hear later about the new Academy of Advanced Practice Research UK. This is one way that we're trying to be collaborative and think about prioritising the research that we need to do in terms of advanced practice across the UK. So, clinical research, we all know that if we have the evidence, we can better support those in our care. We know that research enables us to make decisions about service delivery and change approaches to management and care. We know that we need to involve our patients and public in all aspects of research. And if we do that and ensure their collaboration, we're more likely to have the lasting impact that's going to change lives and services for the better. As advanced and advancing practitioners, we are encouraging all of those that we train to critically engage in research, because we know that this will elevate quality, safety, and efficiency of healthcare delivery. Most of us feel very comfortable as clinicians in the other pillars: practice, education, leadership. But many of us still struggle with how we integrate the research pillar into our practice. If we can come together and support each other, we can find ways that we can do this easily in clinical practice, in audit, service evaluation. We can think about journal clubs. We can think about supporting each other in research projects. And nearly all of the research projects I'm now involved in, we try to make sure we have, people from training, people from clinical practice, employers, stakeholders, public participants, because we know that if we do that, we're more likely to be successful in the research. And we need to remember that, this is about our clinical decision making. We use evidence-based practice in all aspects of our work, and we need to ensure that all of our practice is informed by robust evidence and best practice. We are all involved in training research methods and methodology in our programs, but we need to make it relevant. We need to bring it back to real world practice. And we need to equip our APs to participate in research that's meaningful, that recognises the complexity of the way that they practice, and give them skills to participate and also lead research. But we know that many report that they don't feel confident. Talking to APs over many, many years, they say to me that they're really interested in contributing to research. They want to do it in a meaningful way, but they feel restricted, especially when they start in clinical practice, because of the organisational and practice limitations. And they often find it really difficult to reconcile how they can initiate any substantial research because of the limited time and resources available. So, NHSE have released the Multi-Professional Practice-Based Research Capability Framework, which focuses on practice-based multi-professional research and outlines the common capabilities. And if you haven't had a chance to read this, I do encourage you to do so. There is a lot of work that is going on around supporting people, and I met a wonderful professor in Birmingham who's working on a toolkit for research capacities for advanced practitioners. So we know that many APs really struggle to negotiate, to become able to involve and negotiate time for research, know how to start. And we need to think about how it's going to connect in the very, very busy arenas that we have. And there has been research to say less than 11% of advanced practitioners are able to get involved in research. So the multi-professional framework enables all of those working in advancing practice to engage in practice-based research for optimizing patient experiences and outcomes by enabling them to be routinely part of the research culture. And you'll see when you look at the guidelines that there is a number of areas that we want to support APs to be involved with. So, thinking about sustainability, what can we do? So, we need to make sure that all of us are educated and trained in research, and we need to be creative in how we do that. And I've had the opportunity to work with colleagues internationally and colleagues across the country to think out how we can do this in a way that is much more collaborative, much more sustainable. And many of you will know about participatory research methods, but bringing together all of the stakeholders around the table to co-produce research, to be strategic, to involve everybody in those decisions makes it much more enjoyable, much more collaborative, much more sustainable. So we need to think about all the research that we do. What methodology do we choose? What methods do we choose? And although I teach the Year 3 module in research and run the dissertation module, I'm very aware that many of our trainees come in and think this is the least favourite module that they're going to undertake. And we try to be very creative in the ways that we run it. We're starting to integrate more AI. We're trying to think about other creative methods and methodologies that we can use. One of my students recently went on to do a PhD and used photo elicitation with patients. There is ways that we can help people connect to methodologies that make it much, much more enjoyable for them. We need to think about the resources that are available. If research is going to be sustainable, we do need funding. But those of you who know me know that many of my research projects with colleagues are done without funding. And there are ways round some of those issues. But we need to think about having the right partners, having the right opportunities. We need to make sure that we think about helping people to understand that research should be real world settings. And every study that I'm involved in, and I'll talk a little bit more about those in a few minutes, always has an implementation stage to try and make something relevant to practice itself. If we're going to be really sustainable, we need to think about research that isn't just a one-time snapshot. We need to think about longitudinal studies that give us information about what's happening in terms of AP across the continuum. And we need to think about what the research gaps are. We need to think about widening our teams, as I've said, to make sure we have everybody involved. And we need to make sure that we disseminate our findings. And many of you are teaching the Year 3 students. Encourage them to publish. Encourage them to think about what the next steps are. Think about professional doctorates, clinical doctorates, PhDs, and we're getting more and more APs through the doctoral studies programs. But it is about making sure that we choose topics that show clear gap, that where there's clear gaps, but also topics that have got meaning for us. And that brings me to thinking about sustainability and thinking more about kind of where we go with research. And for me, it's very much about learning from our experiences. And when I think about my own research journey, I've done a lot of work around mental health, I've done a lot of work around spirituality. And when I talk about that, I mean it in the broadest terms about what gives us hope, meaning, and purpose. But, some of our research priorities might come from our childhood. I know for me, I lived with my mom who suffered very much from depression, and seeing the poor care at times she received and how hopeless people can feel with mental health problems really pushed me to think about holistic care and to think about how we could improve care for patients so they feel valued and that they feel that they're heard. We learn from our experiences. So whether that's our hobbies, or for me, I had the opportunity to work in Africa, in Canada, and the Superman picture that you can see there is I took students on a student exchange where we were able to work collaboratively with colleagues in Indiana who were also on advanced practice programs to think about what was important for the students at that time. And we did research around diagnostic reasoning. And, I put there, my hobbies, diving and my sausage dogs. We learn from those experiences as well. And we can still bring those into our research journeys, but it also enables us to have a gap and space to reflect on our work lives and our research journeys, doing things that we enjoy that then give us more energy to come back. And we also learn from all of the hard experiences. So I've been a nurse now for over 30 something years. And through that, I've recognized in my patient journey when patients don't feel heard, when patients feel hopeless, when patients are facing death. And journeying with people has really pushed me very much towards how we can be truly holistic, how we can be, whatever our role is at the time, be there with our patients. And for me, as an advanced practitioner, I want to journey with our patients. I see it as a privilege. I want to learn. I want to integrate research that makes a difference to their care. And I want to be truly holistic. So just thinking about collaborations, and I'm putting this slide on not to show you how much I've been involved in, but to show you some of the opportunities that we can have to be collaborative. So I am very, very lucky that I have met so many wonderful colleagues in the UK, globally, regionally, and each time I develop relationships, I do think about how we can collaborate together. And some of you will have heard me say this, but I'm very passionate about collaboration without ego. There is so much work to go around. There is so much research to be done. There is so much we can learn from each other in education, in leadership, in clinical practice, that we don't need to be thinking about, well, how's this going to benefit my career? Because just by collaborating, you will find that happens anyway, but you will find it much more enjoyable. And I've also learned in terms of my collaborative research opportunities, working with people you get on with who will pick you up when you fall down. So through AAPE, we got very much involved in the Aspiring Advanced Practice program. We developed the workbook, and each of us had times where things maybe were difficult in life and others would pick it up. And to find colleagues who do that, where it's not about, I'm leading this project, so everyone has to follow me. It's about we all have a part to play, makes a huge, huge difference. So think about whether you can collaborate in your trusts, in your teams, in your regions, or nationally or internationally, because opening our um, opening our world up to kind of seeing what's going on globally also is very exciting. So I've had the opportunity to work with colleagues in the US and Canada on diagnostic reasoning, on job satisfaction. I've been involved in global projects on well-being and resilience, and out of that, we've then moved on to an implementation stage of resilience-based clinical supervision, which we're now offering to our trainees. So you can just see there, some of the experiences that I've had, and it doesn't need to be that broad for you. It can be, within your team, it all does make a difference. But as I've said, what is really significant is to be sustainable, is to work with colleagues, is to look at what the gaps are, to look at where there is a need for practice to change, to look at our experiences of what's happening in our practice and how our patients are feeling. And we'll all see that every single day. I still work clinically, and every clinic I have, I see a change that can be made, an experience that could be different for our patients. And for me, that's about listening to those we teach, listening to those we mentor, listening to those we have the privilege of caring for, and listening to what are their priorities, what are their needs. And I'm going to talk a little bit more about priorities later on this afternoon. But some of you might want to look at the recent review of systematic reviews of advanced practice nursing globally that's been produced to look at advanced practice gaps globally. I know that's around nursing, but we are the only country that has gone down the multidisciplinary route, which is absolutely incredible and creates even more opportunities. But if we want to think about what some of the global gaps are, that's a really good starting place. And in the UK, and we're going to talk about this afternoon, we want to do priority setting for multi-professional practice, and we will get your involvement in that. So I'm going to stop there, and I'm going to ask for the panel to come back, and we're going to take any questions and open up for discussion.
Brilliant. Thank you, everyone. That was fantastic. So we're just going to go to some questions. We've had some questions in the chat. Excuse me. First question is for Mel C. From Dawn. So how have you gone about increasing collaboration between education and clinical colleagues to limit conflict?
So excuse me, sorry. So I think ultimately it's about recognizing that you've all got the same vision. So you will obviously get some conflict in terms of different priorities. So I guess one of the challenges is that from a clinical perspective, we might want to have access to modules very locally, but that might not be sustainable for a higher education institute to be able to do that, because to be able to deliver modules, many universities have a minimum number of students that they want to see on a programme. So therefore, it might be about developing some innovative ways to be able to develop curriculum design and be able to share that as well. And just to have the same sort of outcomes in what terms of what people are looking for. And if there is some conflict, just trying to find some common ground, and recognising that actually there is challenges in the workplace that are going to be very different from a HEI perspective, and actually getting some understanding of how that might work out and what people's priorities are, which might be slightly different. So I think there's a few ways about trying to sort of limit that conflict. But ultimately, if there's a shared vision, then that's what increases that collaboration, because you've both got the end goal. But there obviously is different challenges depending on the different areas of practice that people are coming from, be that academia or be that from the NHS or healthcare.
Fantastic. Thank you, Mel. So I've got a question for James from T. Mallinson. So for James, are there any consensus statements for required clinical examination skills for advanced practice programs? Made a point that there seems to be huge variation.
Simple answer, no. I think it's really difficult to set statements along that sort of level of detail, because then you're getting into scope of practice, aren't you? So I think if we're asking a national set of scope of practice as such, and we're getting into the nitty gritty of what individuals should be doing, then you lose the beauty of advanced practice. Now, you could do that per role and within specialty, and you could do it to certain professions to a point, but you do have to be quite cautious about identifying exactly what it is an individual would do and what they need to be signed off against, etc. And you do see a variation, and I think that's why it's important you engage well with your AGIs, because particularly from a clinical examination and from that decision-making side of things and some of the stuff around pathology and things, actually is what you need, and they can't fill the need for every single person, but as an employer we need to support that as well. So I think something which has to happen from an employer perspective is you need to define what it is that you need in your organization as a consensus for all your advanced practitioners. So we've done that for, say, the role of advanced clinical practitioner here, where there's a clear set of clinical competencies, which includes examination skills, which everyone has to have. But that's for the role of ACP. That wouldn't work for our advanced therapeutic radiographers, for example, because they'd need something different. But we do define that. That's our responsibility as an employer to do. What you can do is speak to your HEIs first to make sure what's being delivered on the course is meeting your needs, but also realize that often you need to meet the needs internally as well. And it's a collaborative relationship, because the expertise often sit within the organization already, while the academic expertise often sit within the university, if that makes sense. So I think it's impossible to do, but it's something that has to be done within an organization and get a consensus of competency and capability of what you need from a governance perspective.
Brilliant. Thank you, James. Excuse me. Next question for Mel Rogers. And this is from Amy Foster. So Amy is saying that she would like to do research as part of a PhD in a clinical area. However, Amy now has a purely academic role. And do you know, or has anyone navigated gaining support from a local trust, etc., to collaborate or navigate undertaking a joint venture?
Yeah, I think the options, there are a number of options, and I'm more than happy to be emailed to talk about it. I think trying to have an honorary role with a practice. So if you've got a clinical background and you're in academia, I have a honorary role. I work at our local university health centre, and I'm able to do some joint research with them. So that's certainly one opportunity. There are obviously opportunities for clinical doctorates, professional doctorates, but I do a lot of work. I run a couple of special interest groups, and they are joint collaborations with the trusts. So they enable us to have that access into clinical practice. We've just finished one looking at perceptions of spirituality in the trust, and having that joint partnership meant that we had access to service users in the trust as well as clinicians. So I think those are probably the three recommendations, but I'm more than happy to be emailed, and we can chat about that.
Brilliant. Thank you, Mel. Another question for James. This is from Chris. Is there a risk of multiple portfolios that don't talk to each other?
Yes. I think definitely, but I think what you need is setting there's different bits. When you think about competence and capability and portfolios, is you need to, in the first instance, from a CQC perspective, Health and Social Care Act perspective, we need to ensure as employers that our practitioners are meeting the level of competency and capability for them to do their job. The portfolio, an e-portfolio, allows that. The trouble is with portfolios which are given necessarily by colleges or by universities is they're broad, so they cover everything and not necessarily localized. So it's how then as an employer can you utilize what may be seen as the national standard and then what needs to be additional to it. What you don't want is, already there's multiple portfolios, but do they necessarily need to talk to each other? They need to be recognized. And I think from a university perspective, what I'd like to see more HEIs do is recognise national portfolios which are at a standard out there already and have them in a process which allows them to carry credits Now, how that's done, whether that's through a review process of the portfolio or whatever, rather than the university necessarily setting it. But the universities do have to do that sometimes, because there's a whole group of staff out there who don't have portfolios. There isn't a set of competencies or capabilities, and they need to be set locally. So there is a risk. But as an employer, so if I think of where we work, we have the NHSE portfolio, which we run for everyone. We have about over 30 versions of different competencies and capabilities in there, but the generic STEM, which matches the national capabilities, but our generic clinical STEM stays the same. Then you add your specialty specific ones on. But by having a single portfolio, which has lots of different curriculums in as such, allows progression over time. Now, there's places who are setting it really well as like across an ICS, and we'd love to have been set nationally many years ago, but I think that has bolted now. So we have to think of it locally. But that has to be done in partnership by universities, because what you can't have, and we still have it so often, is trainees going to a university and being asked to do, I don't know, Pebble Pad, and their employers are saying, now you do NHSE portfolio, and someone else saying, oh, I should actually have done FICM alongside this, but that's a paper portfolio, do you know? So then it becomes a big conflict, and it's who's got the most. That's where the collaborations and the partnerships have to happen to ease employer workload, but supports your governance as well and helps the university. It's challenging space to do it in, but people have done it. So yes, of course, there's a risk of conflict.
Can I just come in on that one?
You can, Mel.
So, having been involved in the e-portfolio and some of the programs as well, it is massively challenging and it is a huge burden for practitioners. But one of the rationales around the HEI sort of stance on portfolios is how to assess at level 7, and how to get that critical reflection and that criticality of thinking. Yeah. And in some of the portfolios, not all of them, but some of them don't lend themselves to developing that sort of evidence. So sometimes it can be quite descriptive or quite task focused. So sometimes then there needs to be something else to be able to develop that assessment against that criticality of what we expect at this level of practice. So there's probably a lot of challenges and barriers, but absolutely that collaboration is helpful, because there is ways to share that evidence with the HEI portfolios, downloaded it and things like that, so you don't have that repetition. So I think that's where HEIs need to be aware of the different portfolios that are out there and say, you know, that part perhaps doesn't meet the need of the assessment, but actually you could download X, Y, and Z, because that supports the evidence of what you're applying that criticality to.
Yeah, no, I agree. And I think sometimes that criticality actually shouldn't sit within a portfolio, it should sit in that other bits of academic study within other parts of modules. And I think that's where because the challenge is, as employers, we're sending people to universities and sometimes we're expecting them to come out clinically competent and capable, but that's not the responsibility of the university alone. That's our responsibility as well. The responsibility of the university is to make sure they're academically competent and capable, I think. And then the other bit is a partnership, and it's how you ease that load, but it allows you to build governance and assurance in your organization as well. That's the key piece. And that has to happen through a partnership and collaboration. If not, you end up with two things running, clashing against each other as they go.
Yeah, thank you. Yeah, really good points. Brilliant. Okay, thank you. So just a question from Mel C from Piran. What challenges have you found to achieving sustainability amidst an ever-changing advanced practice environment?
So some of the challenges that I find, because I work in quite a niche area in terms of radiotherapy and oncology, is making sure that we've got sustainable modules and how we make sure that they are available for practitioners. And the fact that within some institutions, perhaps we can't run some of those modules, and how we need to link in some of those areas. We're also quite a fast-paced area of healthcare as well, so technology advances really quickly. So actually being able to implement that into some of the educational components can be tricky. From a HEI institute, it can take 18 months to set something up, for example. So there is some challenges in being able to develop things that are sustainable and that are appropriate for healthcare. And obviously there's the changes around funding, So we have to be quite agile as well as sustainable in terms of the delivery of the education. So I guess there's some of the challenges, but it's about having that open communication and conversation. Things like this of, hearing James's point of view around portfolios and all of that type of thing. Having that open communication will then strengthen the sustainability of what we have to offer in a very sort of agile environment.
Fantastic. Thank you, Mel. Okay, I think we have time for one more question. So this is for James. This is from Andrew Monday. So addressing supervisor accountability, sort of legal regulation, it's around that aspect, and the challenges. Saying that a challenge is that medicine's regulated by GMC and that practitioners do not always come from the same trusted pathway of training and education. So I guess it's just your thoughts around supervisor accountability regulation.
Okay. Hello, Andrew. I've seen you for a while, so it's nice to hear from you. Tough question as always. So I think, again, with the regulation piece around supervision, so supervisors obviously are part of, not necessarily the regulation piece, but we're talking that they sit very much in college pathways and deanery pathways, don't they? So the first thing that's most important to ensure good quality supervision is funding. And that funding has to be thought about at the start of workforce planning. So, and that has to work by collaboration within your organization with the right people from a finance perspective. It can't be an afterthought, and it can't just end at the point of a trainee. It needs to continue throughout that career. So that's the first thing I think. And then you need to think about how do you then govern the skill set and knowledge within those supervisors. So setting a standard, what you see as a minimum standard of supervision for this supervisor, which you can utilize some of the NHSE stuff, but working out what you need as an organization, that is a minimum standard, remember. So that doesn't mean that is the maximum standard. So you could push it as far as you like. So then what education development do they need as supervisors? How then do you assure, though there's money there for their time, that time happens? And for me, we have here is a reporting process, so I can see how much supervision time people are having, but it's not thought about as an afterthought. And then it's about how you then further develop your supervisors as well. So what does that development look like for the supervisor as well? Because good supervision, and there's a difference in my mind between supervision and assessment. And often we talk about them together, and it sort of frustrates me a bit, because assessment for advanced practice is often you are now able to do. While supervision, I'm talking more from that formative perspective, that support, restorative supervision, that's a different piece of work. And I think you have to have within your organization written in policy to the level of which you need. But again, engage with your universities, because universities can develop the supervisors. We certainly see in the trainee perspective, and this is where the apprenticeship really helps, because you can hold them against something saying this person isn't getting X, Y, Z. They need to get this, this, this. You signed up to this at the start. But it's that joint process again. I think you could go to some organizations who do it really well and have it written down really nicely, but it actually doesn't happen on the shop floor. So it's about how you get the reporting pathways in as well to do it. And I think we can utilize tripartites, things like that for trainees to do it. But it is a difficult space to work out and build sustainability. And I don't think it particularly answers your question altogether. And I'll have a bit more of a think about that one. It's going to tire my mind.
Thank you, James. I'm afraid that's all the questions we've got time for this session. Well, I did have one for Mel R. Hopefully, you might be able to pick that up this afternoon in your session. So we're going to go to coffee now. Should have a slide coming up with sort of access, so how you can access our poster submissions. So over coffee, if you could have a look at our poster submissions, the links will come up. I can see that they've been put in the chat as well, and also voting on the Slido function. Again, as Anna said at the start, I want to say a huge thank you to our sponsors and our partners, Hallam, who have sponsored prizes for the posters. So there's book tokens of £150 for the first prize, £200 for the second prize, £50 for the third prize. So if you could join coffee, obviously you can stretch your legs, have a break, have a coffee, but also have a look at our posters and access to the Slido. If you look in the chat, you'll see that we've put the links in there. Everyone can be back here at 11 o'clock, ready to start, and we're going to hear from Paula McLaren at 11. So we will see you all at 11 o'clock. Thank you.